Our next section is thyroid disorders, hypothyroid, hyperthyroid, thyroid nodules. This is an incredibly common disorder, probably the most common of all the endocrine disorders. As much as 5% of the population has a nodule or hypothyroidism. Since step 2 of USMLE is a clinical examination, the first thing to look for in the presentation is to say, well, bradycardia versus tachycardia, to answer the question, what's the most likely diagnosis? Since this isn't a basic science exam, we don't have to go through a lot of the steps in the production of thyroid hormone. But we generally know that thyroid hormone speeds things up. So if you don't have thyroid hormone, you have bradycardia. Too much thyroid hormone, tachycardia, palpitations, atrial fibrillation. Low thyroid, you're constipated. Well, hyperthyroid, you're not exactly diarrhea, but certainly a hyperdefecation. And that's because it's an increased frequency. It's not a wateriness as much as going more often, because the bowel is simply moving more. Weight gain for hypothyroidism, which must mean you get weight loss for hyperthyroidism. You're tired, nothing works. You're fatigued and lethargic and comatose, if it's super severe, comatose. And that is because thyroid hormone controls the sodium, potassium, ATPase on virtually every cell in the body. So if you're hyperthyroid, you'll get anxious and nervous and jittery. Increased sympathetic stimulation makes you tremulous. That's why in hypothyroidism, you'll have decreased reflexes, a decreased relaxation phase, hung reflexes. It goes up, bang, and then down slow. Whereas hyperreflexia and certainly tremor with hyperthyroidism. People can't handle the cold when they're hypothyroid. They can't handle the heat when they're hyperthyroid. And finally, hypothyroidism makes dry skin with coarse, thick hair and hypothermia. And hyperthyroidism makes you sweaty, sometimes febrile, with thin, fine hair. In hypothyroidism, generally speaking, everything is slow. And hyper, everything is fast. The cause of hypothyroidism is almost always, most of the time, from simple failure of the gland. It's sort of like a postmenopausal thyroid. It's failure of the gland from burnt out Hashimoto thyroiditis. An acute phase of hyperthyroidism is rarely felt. It can also be from a deficiency of iodine or amiodarone, because remember, amiodarone chemically looks a lot like thyroid hormone, has a lot of thyroid manipulations. And what you should look for is that everything in hypothyroidism, everything is slow except menstruation, which is increased, menorrhagia. The best initial test for hypothyroidism is that when you have a person who is hypothyroid, you should be looking for a TSH, and a TSH that is markedly elevated is with the gland that has failed. If the TSH is suppressed, what you should be looking at is that T4. But the bottom line is, for hypothyroidism, get a T4 and a TSH almost all the time. If the gland has failed, the T4 level will be low and the TSH will be high. And it's easy, hypothyroidism. Just replace. But don't replace too much. If people have coronary disease, you'll provoke a myocardial infarction. Hyperthyroidism is a bit more complicated because you have multiple causes. You got Graves' disease, simply an overactive production of thyroid hormone. And it's also the only one that has eye and skin findings. The others do not have eye and skin findings. Eye and skin is unique to Graves' disease. Gee, what's the difference between proptosis and exophthalmos? The answer is nothing. Nothing. Subacute thyroiditis is also characterized by a tender gland. That's why the term painful thyroiditis or de Quervain's thyroiditis in the past was used, because it's the only one that actually hurts. Now that's to distinguish it from painless or silent thyroiditis, which is non-tender, has essentially a normal physical exam of the thyroid gland anyway. Now what about people who just feel the need to lose weight, so they start taking thyroid hormone to lose weight, which will work? Well, the gland is gone. It's missing. Involuted gland isn't palpable. The same way guys who abuse testosterone get really big deltoids. Oh, your pectorals are so large. But I notice you're taking that testosterone. I know something about you that's very small. Well, the same way people who abuse sex hormones, particularly men, they get teensy tiny little raisin-sized gonads and testicles. The same way that people abuse thyroid hormone for weight loss purposes get a teeny tiny little gland that can't be found. So why is it that people who are athletes, why don't they abuse thyroid hormone? They take growth hormone. Of course, IGF makes muscles grow, gives you energy. Boom. Of course, they'll take testosterone, makes those muscles grow. Could take erythropoietin, make the hematocrit grow up. So why not take thyroid hormone? Well, that's because at pathologically increased amounts, excess thyroid hormone actually consumes muscles. It'll actually start to break them down. It'll actually start to cause a thyroid steroid-induced myopathy. Now, pituitary adenoma is the only one of the causes of hyperthyroidism that's associated with a high TSH. None of the others have a high TSH. All other forms of hyperthyroidism have a low TSH. High T4 thyroid hormone and a high TSH equals a pituitary adenoma. Hyperthyroidism, you get a thyroxine level, the thyroxine level is elevated, and it's elevated in all forms of hyperthyroidism, but the TSH level will only be up in TSH producing pituitary adenomas. Pituitary release of TSH is inhibited in all forms except that pituitary adenoma, which will have the high TSH. Graves' disease has the unique features. It's the only one with eye and skin findings, and it has an elevated radioactive iodine uptake. And you might say, well, wait a second. I thought radioactive iodine was used to get rid of the gland. I thought radioactive iodine was used to ablate the gland. And the answer is, it is. But it's a different type of radioactive iodine. There's diagnostic radioactive iodine and therapeutic that obliterates and ablates the gland. The same way we have radiation, where you can take a CT scan of a head, and radiation where you can use on a brain tumor. So Graves' disease is simply an over-functioning gland because of thyroid-stimulating immunoglobulin, thyroid-stimulating antibodies. They're essentially antibodies that act like TSH. They turn the thyroid gland into the on position as an autoimmune phenomena and give you an elevated radioactive iodine. TSH receptor antibodies are found, and that is also unique in Graves. There's very little utility for all of these immunoglobulins and antibodies in any form of hyperthyroidism, and Graves' disease is the only one. Here it is, Graves' disease ophthalmopathy. Is that proptosis or exophthalmos? And the answer is it's both. It's either, and the best initial therapy is steroids. Steroids can be used to prevent the accumulation of that glycosaminoglycan in the back of the eye so that it doesn't push your eye forward anymore. And if you're not responsive to steroids, for those unresponsive to steroids, the therapy is radiation. Wow, if nothing else works, what if they're unresponsive to everything? You actually have to do decompressive surgery. And why this is important is all that stuff, the mucopolysaccharides accumulate behind those eyes and push them forward, can actually crush the optic nerve. So you need to decompress it and stop it before it can crush the optic nerve and blind the patient. Graves' disease is the only one that gets radioactive iodide. You take advantage of the fact that the gland is hyperfunctioning. You inject radioactive iodide. The iodide will be picked up by the gland, and the gland will be ablated and destroyed by the radioactive iodine. Subacute thyroiditis is only treated with aspirin. It's an anti-inflammatory. When you get rid of the inflammation, the gland problem goes away. Painless, silent thyroiditis, well, that's like antibodies attacking your thyroid. And a thyroid gland is sort of like a ball of littler balls filled with thyroid hormone, that colloid. And when the antibodies rip off the coverings, well, it's sort of like stepping on an orange. It gets juiced, but there's nothing you can do to repair it. It'll calm down on its own. Although it may burn out to hypothyroidism, there's still nothing you can do. People who abuse thyroid hormone just have to stop it. There's nothing you can do. And if it really is a pituitary adenoma, if it really is a person with a TSH-producing adenoma, there's no medical therapy for it. You have to get up the sphenoid and remove it. And in that thyroid storm, we saw profound hyperthyroidism, and everything was stimulated, and you had tachycardia, and maybe some chest pain, and anxiety, and panic attacks. And the best initial therapy, the fastest thing to work, is propranolol. Blocks target organ effect. This is one of the only uses of propranolol anymore. Non-specific beta blocker. And also inhibits peripheral conversion of T4 to T3. Propranolol is used for essential tremor. Propranolol is used for migraine prophylaxis of panic attack. And it's used for thyroid storm, where we want to block both beta 1 and beta 2. Most students won't know that it blocks peripheral conversion of T4 to T3. That's one of those ways, one of those little things right there where you're going to edge above everybody else. Thiourea drugs means methimazole and propylthiouracil. These drugs block all of the steps in thyroid hormone production in the gland and even some effect on peripheral conversion. Now, why the thyroid hormone peripheral conversion is such a big deal is this. T4 is much less active. It's converted to T3 with 3 iodides on it. If you can block the conversion to the much more active form, you can really shut off thyroid hormone effect very quickly without having any major adverse effects. Continuing with the treatment, iodinated contrast material blocks up not only the peripheral conversion, but the release of existing hormone. You see, iodine, you might say, well, how does it block it? I mean, I thought that iodine was how you made thyroid hormone. That's true. But if you give a super high amount, if you give much more than usual, it'll block it up. The same way it's like your toilet. It's meant to receive toilet paper, right? But if you use a really large amount, it'll block it up. So it blocks the peripheral conversion because literally T4 to T3 is removing an iodine. If you give a ton of iodine, how can you go down from 4 iodines to 3? It literally keeps that iodine up there and blocks the conversion to the more active form. Steroids, it's hard for people to understand that the role in treating hyperthyroidism is blocks peripheral conversion. It blocks peripheral conversion. And radioactive iodide is more permanent. That's how we go for the cure, how we go for the ablation, get rid of the whole gland in general. It's based on dosimetry, which means you measure the size of the gland and give just enough to cook most of the gland. And the problem? Well, you go too far sometimes. But you know what? It's easier to manage it when people go too far and you burn it out. It's easier to manage hypothyroidism. Just replace the thyroid hormone. Thyroid nodules are found in 5% of women, 1% of men. Wow! And fortunately, 95% are benign. But isn't it amazing? 1 out of every 20 women you meet has a thyroid nodule at some point in their life? That's amazing. Well, you've got to distinguish between the adenoma, colloid nodule, and cyst. And you've got to distinguish which thyroid nodules are hyperfunctioning. See, that's the key issue. If it's cancerous, it's not hyperfunctioning. If it's cancerous, it's like a criminal. Do criminals pay more taxes? They pay extra taxes? Do they put extra food in the store and extra things on the shelf? Do they work more? No. Criminals generally don't contribute. And that's why cancer is non-functioning. If you see something hyper-functioning, it is not a cancer. A 46-year-old woman with a small mass on palpation of the thyroid comes in and she's got no tenderness. She's otherwise asymptomatic. What's the next best step in the management of this patient? The first thing for a woman with a small neck mass is, wow, T4 and TSH. Why? Because you've got to make sure it's not hyperfunctioning. You know, if you have a fine needle aspiration, well, you know what? If it was a hyperfunctioning gland, a hyperfunctioning nodule, it wasn't cancerous. So there's no point in doing that. First, you have to say, is that thing functioning? Because a hyperfunctioning gland does not need to be biopsied. You do the fine needle aspiration if the thyroid function tests, TFTs, are normal. Nuclear iodide uptake scan is useful in determining an etiology of functionality, but not enough to spare you the need for a biopsy if you have low or normal functioning. Radioactive iodine is for hyperfunctioning. It's like evaluating toxic nodular goiter. It's for evaluating Graves' disease, but it's not for evaluating a person who has normal function. The same as a thyroid ultrasound. The thyroid ultrasound is not a substitute for the biopsy. It's to guide the biopsy. The surgical removal is if your biopsy comes out as follicular adenoma. Now, follicular adenoma in the thyroid is kind of a unique phenomena. It's something that you can't really tell if it's cancerous or benign, so you take out the whole thing with an excisional biopsy. When you have a thyroid nodule, make sure that the function is not elevated. If the function is elevated, don't biopsy it. If the function is elevated, do a nuclear iodide uptake scan to determine why it's elevated in function. You biopsy with a fine needle aspirate in the office if there's normal thyroid function. The sonogram, the ultrasound, or nuclide scanning cannot tell you if it isn't cancer, cannot exclude cancer. In other words, a sonogram and radionuclide scanning is not required because these tests can't exclude cancer. If you have a cold nodule, you need to biopsy. If you have a hot nodule, you need to biopsy. So therefore, it doesn't matter what they show. That's one of the most common wrong answers. Any nodule that's not hyperfunctioning, any nodule with normal thyroid function equals needle biopsy. 46-year-old woman with a thyroid nodule, normal thyroid function, has a biopsy showing indeterminate for follicular adenoma. What are you going to do about a follicular adenoma? The answer is remove it. That's the only way you can know whether it's malignant or not. A CT is not going to make a diagnosis of cancer. It won't tell. Only an excisional biopsy can. And the sonogram is a step back. Can't exclude cancer, and you've already done a biopsy. Calcitonin cells are for medullary carcinoma of the thyroid, but not for this. It's too soon. Excisional biopsy for follicular adenoma.